This video will have information on cardiac catheterization and cardiac angiogram. The focus will be on the lower extremity site, although note that more and more you're going to see radial and brachial sites being used, but because right now the majority of sites are done through the femoral artery, the video will focus on that. So cardiac catheterization can be both diagnostic and treatment. It has a lot of different names out there, and we have some of those listed here. So it does depend on whether they've done an intervention or not, if they've done angioplasty, which is the ballooning, if they've left a stent. So you might see different names, but basically we're talking about the same procedure. I do want to mention that if they do have a stent put in, they will be on anticoagulant or antiplatelet medication for life while they have a stent in. So you can see if we are using the femoral artery site, they're going to obviously go in through the femoral artery and thread the catheter up to the heart. This image shows you before and after. So you have the right coronary artery, and it is then opened up with a balloon, angioplasty with a stent left behind, and it's a 4mm stent that's in this particular image. So you can see once you have the angioplasty and the stenting, how the blood flow is returned to that area, improving perfusion. When they go in with the catheter and they get to a plaqued area, which is on top, you can see a plaqued area in the artery, they're going to use that balloon to compress the plaque that's in the artery to push it up against the artery wall. And then most of the time after you're done doing the ballooning, they will deploy a stent and leave that stent in the artery. And so then you can see how perfusion is now restored in that area. Again, just some more images showing you how the catheter goes in through the artery and then is threaded into the heart. It can go into these arteries here and do any intervention. And like I said, it can be diagnostic as well, because they might just be going in and they're getting pressures, ejection fraction. They might be looking to see if there are any areas that are plaqued that need intervention. Maybe the intervention that they need is too severe for this particular problem. They can look at the functioning of the heart valves, and so you can get a lot of information through this. You do have to remember that there is dye that is injected during this procedure, and that's so they can see what's going on the screen. So they're looking at everything under fluoroscopy. So the patient will get dye during this procedure. So thinking about prepping the patient beforehand, they'll have to be told the procedure, they'll sign a consent form. That will be the responsibility of the cardiologist. They'll have to know information as to when they need to be NPO, when they should stop any medication such as anticoagulants, if they're diabetic, do they take their insulin, those types of things. They'll also have pre-op lab work done, and that might be done the day of the procedure, or the provider might have ordered it prior to the procedure. It just depends on that particular provider. A lot of times you're looking at their blood counts. You don't want to ever put a patient into a procedure if their blood counts are too low. Although there's very minimal blood loss during a cardiac catheterization, we want to make sure that we would never send a patient with a hemoglobin and hematocrit that's too low. Electrolytes are important as well, because we are putting a guide wire into the heart, and that can cause some irritability, and we don't want to put anything into the heart if they're already at risk for any irritability. So if you have, let's say, a high or low mag, a high or low potassium, that can increase our risk for ventricular dysrhythmias, and so we don't want to irritate a heart that already has risk for that. Definitely need to know their coagulation profile. So if they're on any type of anticoagulants, they should have stopped them several days before, and we want to make sure that their PT9R is not too high and that they're at risk for bleeding. At sometimes you might do a cross-match type and screen to see, to have blood ready, but a lot of times that wouldn't be expected if their H&H is normal. So you might have that, but that's not always very common. Preparation of the site might be done in your pre-op area. It might be done actually in the cath lab, so it just depends on your site, but the site will be shaved and it will be prepped with typically iodine. But of course, if they have any type of iodine, they might be using chlorhexidine and something else to clean the site. We do also need to worry about any allergies to iodine because of the dye that they get. So They do have to get the dye during the procedure, but if they have an iodine allergy, they will be given some pre-op medications like prednisone, Benadryl, Tylenol beforehand. Renal failure patients, I have a hard time getting that dye out of the system, so a lot of times that is why they are hydrated before and after the procedure to help push that dye through the system. Usually we're talking about increasing their fluids as well, but if this is someone who's an end-stage renal failure patient, you typically would expect that they will have dialysis then, that day or the very next day in the morning to help get rid of that dye that's built up that they're unable to excrete. So after the cardiac catheterization, they are going to have some type of bed rest. It's going to depend on how they closed the site and again, what site they use. So if they're using the radial or the brachial, your bed rest will be different, but if it's the femoral artery site, typically bed rest is anywhere from 4 to 6 hours, could be longer if they have any post-procedure complications. They will be on cardiac monitoring, so you'll be watching them for any dysrhythmias because we were manipulating inside the heart, they have that risk, so we're watching for that. You'll be watching the site for any problems with the site, pain, hematoma, anything like that. And typically you're following post-procedural vital signs, so Q15 times 4, Q half hour times 2. So you'll follow whatever the provider orders or whatever whatever site specific, but that's kind of the general. You'll also make sure that you're looking to make sure that there's no vessel occlusion. So if for some reason that artery would become occluded, again, whether it's the groin or the brachial, that would mean that there would be no blood flow to the extremity below that point. So that's why you're assessing color, temperature, pulses, all below the insertion site as well. So you're not only monitoring the patient cardiac-wise, you're monitoring the site and then the extremity below that. And so that's why it's always a good idea to know what were these pulses beforehand because they should not be any different. You'd always be monitoring for any signs and symptoms of dye allergy, and we'd be watching their electrolytes and their intake and output after the procedure. As with any procedure, there are multiple potential complications, and those are kind of all listed here for you. And these are specific to the heart. There's also vascular complications having to do with the site that you use. So you can see those listed here, with hematoma being the most common complication. So, when you're doing your assessments afterwards, you're really watching to make sure that they don't have a hematoma. If a hematoma develops, you're going to see, a bulging mass underneath the skin there. And so they might be having some pain, burning. They may have some bruising initially, or they will get bruising afterwards. And so typically, if you have a hematoma, you're going to be applying some pressure there to soften out that hematoma, get the bleeding that's happening underneath the skin to stop. And then you're kind of increasing your assessments now. So you'd be assessing more frequently, you'd be contacting the provider. You always want to outline the area so you know it's not getting any bigger. And the provider, once you've notified them, they may decide to increase the bed rest now. So typically, if bed rest was only for 4 hours, now maybe you've added 2 hours to that. And they might ask you to apply a compression device, which is on the image there. That's a FemStop, and that's a compression device that will be put on there again to make sure that bleeding doesn't occur again and that hematoma dissipates. There are some problems if hematomas occur. So if a hematoma is there, obviously they're losing some blood, and sometimes they can lose a lot of blood, or it can a hematoma will develop and the bleeding will stop. But with that hematoma being there, you can have compression of nerves and vessels. So again, an important reason why we want to watch for that. There's also risk for compartment syndrome. Again, that's a very rare complication, but can happen. So we want to make sure that, when we're taking out the sheaths, they should only be removed by people who are trained to do that. They should be doing it in proper positioning and following the restrictions afterwards. We can also see hematomas developing with patients who don't follow their restrictions. So being on 4 hours of bed rest with only being able to lift your head up for 30 degrees after the first hour can be difficult for patients. So you can see them, a lot of times fidgety patients, forgetful patients, patients with back pain who just have a hard time laying flat and are moving more, you can see an increased risk for hematomas developing. And just to mention, they can occur while the sheath is still in place. That's going to be less common, but that can still occur. So if your patient comes back from procedure and has the sheath in for an extended period of time, you're still monitoring the site very frequently, usually every 15 minutes until that sheath is out. Pseudoaneurysm, again, as we go through them, their likelihood of happening is decreases, but here we have a dissection or a tear in the inner wall of the artery, and so you'll see kind of a dissection. You can have a hematoma that's happening, that's enlarging the vessel. So the patient is going to complain of some tenderness or some pain. You may feel a palpable pulsatile mass. If you listen with your valvular stethoscope, you may hear a bruit. So again, this would be something you would contact the provider with. You're going to be increasing your vital signs usually every 15 minutes until you get further orders or direction. And they may decide to do an ultrasound if they believe this is what's happening. An ultrasound will rule this out. And if they need to, they may do a thrombin injection to remove any clot that's there. Retroperitoneal bleed, again, a less common complication, but a very deadly complication. So for this, you have where blood is leaking into the retroperitoneal cavity, and the way it's leaking, you're not seeing any hematoma or anything. It's usually when there's a higher up leak, so it's not in that groin site where it's leaking. The leaking is up higher in the artery. And the patient will begin to complain of severe back pain, severe flank pain. And this is where it gets tricky sometimes, because you'll have a lot of patients complain of back pain because they've been laying flat for so long, but you really have to watch all your other signs and symptoms. This person is bleeding into that retroperitoneal space, and you can't see it, so you don't know it. So you're looking for these signs and symptoms. A lot of times a big sign and symptom is a patient saying that they have to have a bowel movement. They feel like they're gonna go right now. You put them on a bedpan, you try all this, they can't go, and they have this kind of severe pain and that they have to go. But they're also gonna begin to start having some hypotension and some tachycardia because they are losing volume. So all of those kind of signs and symptoms together are gonna alert you to that this might be going on. So you're gonna get in touch with the provider right away. You would expect that they would do a CT scan to rule this out. And if they are bleeding, having retroperitoneal bleed, they will have to have surgical intervention to control the bleeding. So again, you're monitoring them frequently. When you have a patient who is a smaller patient compared to a larger patient, a more obese patient, sometimes these signs and symptoms don't show up, the pain and that bowel movement urge, as soon as they would in a smaller person, because in a larger person, the retroperitoneal cavity is larger. So just something to kind of keep in mind if you're seeing changes in blood pressure and heart rate, and you're worried about blood loss, and it's a larger patient, it could be that they have more area for blood to fill in. So you can see here's more about retroperitoneal bleed. You can get 1 to 1.5 liters in that peritoneal cavity, and even more again if the patient is larger before they begin to start having some of the signs and symptoms. So again, making sure that the provider knows what's going on. You may need to give some blood, you may need to give some fluids. It'll depend on how severe the bleed is for the patient. And then just signs and symptoms of hypovolemia to refresh for you. So typically, if someone is losing blood, their heart rate is going up, their blood pressure is going down. As this continues, they're gonna have decreased urine output, they're gonna become pale, diaphoretic, very cool. So just refresh those symptoms. Also, you can look at the mean arterial pressure. And so normal mean arterial pressure, or MAP, will be 70 to 105. And usually when it begins to get below 60, this is where you're gonna start seeing some of those hemodynamic changes. So some of your electronic computer systems, some of your electronic monitoring will figure out the MAP for. Okay, so fistula can develop, and this is abnormal connection between the femoral artery and the femoral vein. Again, a less common complication, but can occur. And again, frequent assessments, notifying the provider, and an ultrasound will help rule out this problem. Occlusion, again, we keep getting more and more rare complications, but can happen. And this is why it's important that we are assessing the extremity below the insertion site. So if it was the femoral artery, it'd be the pedal pulses, lower extremity. If it was a brachial artery, we'd be looking at the lower part of the arm and the hand, radial pulses. So if you have any signs and symptoms of occlusion, again, increase in your assessment frequency, contacting the provider, and they will do an ultrasound to see if there is an occlusion. So that concludes cardiac catheterization complications.